After welcome to Easy Anatomy. After talking about neck fascia, we have to talk about facial spaces in the neck and the head, and how this is relevant to spread of dental infection from oral cavity down to thoracic cavity and different spaces in the neck. So basically, to make it easy, just remember I'm going to start with mylohyoid muscle. This is mylohyoid line, correct? And you have two mylohyoid muscle that meet in the midline and attach it to the hyoid bone. And they form the floor of the mouth cavity, correct? So this is mylohyoid muscle. So mylohyoid muscle split the oral cavity in two spaces. The space above here is going to be sublingual space. The space down here is going to be submandibular, or sometimes we call it submaxillary, submandibular, referring to submandibular gland, and this is sublingual. Okay, remember that this bone here is is hyoid bone. This is the hyoid bone. Okay, and the mylohyoid muscle extend, as I told you, to the hyoid bone. Keep in mind that posterior to mylohyoid muscle and meanwhile extended deep to mylohyoid muscle is going to be which muscle? Hyoglossus muscle. Hyoglossus muscle. Hyoglossus muscle extend from hyoid bone up to the tongue, right? And is going to extend deep. So this is the sublingual and this is submandibular. If I ask you, infection here in the sublingual space, can it spread to the submandibular? Yes, it's going to spread behind, can extend behind. If there is infection here and the accumulation of fluid here, posterior to mylohyoid muscle can go to the submandibular space, and once it comes to submandibular space, it still can spread on each side to the parapharyngeal space, around the pharynx, and it can extend down to the neck and mediastinum, down here mediastinum, which again is the central part of thoracic cavity. What are structures located in the sublingual space? Remember, structures here are going to be sublingual gland, correct? Then, do you remember the nerve which extend between mylohyoid and hyoglossus is going to be what? This nerve is going to be lingual nerve. And the lingual nerve is closely related to which duct here? Here is submandibular gland. This is submandibular gland. Part of it superficial to mylohyoid, and part of it extend between mylohyoid and hyoglossus muscle. And from there, this is submandibular duct. Submandibular duct extend deep to mylohyoid, and it is closely related to the lingual nerve. So at the end of the day, if I ask you what are structures located in the sublingual space, you will see sublingual gland, Wharton duct, this is Wharton duct, and lingual nerve. Also you will see terminal branches from lingual artery. Lingual artery also is going to be part. So again, contents of sublingual space, because this helps you to understand the symptom and signs of infection in sublingual space. Contents of sublingual space are going to be sublingual gland and duct, Wharton duct, lingual nerve, and terminal branches from lingual artery and vein. Okay, submandibular space, you will see submandibular gland is part of it. Okay, nerve to mylohyoid, and those are structures located here. Okay, lingual nerve is going to be in the posterior part of the space. So this is just to start understanding spaces here in upper part of neck, which you call them suprahyoid space. Suprahyoid space mainly sublingual, submandibular, on each side parapharyngeal and parapharyngeal. Okay, around the pharynx, parapharyngeal. Infection in this area, bilateral infection. If you have bilateral infection that affect submental area and submandibular area and sublingual space, this infection which extend both sides, it can be fatal, and we call it Ludwig angina. And the reason that it's fatal, the mortality rate used to be high, but right now significantly changed because of the antibiotic. It used to be 25% mortality, now it's 5% only because of the antibiotic. And it is fatal because imagine that there is bilateral infection here. The end result is going to be elevation of the tongue and obstruction of the airway. Elevation of the tongue here and backward, and obstruction of the airway. This is a Ludwig angina. Okay, I take you back to the masticatory space, and if you remember, we talked about mandible. Here is mandible. Which structure located, or which muscle connected to the mandible from outside? This is masseter, okay? And then here is zygomatic arch above, and then you have temporalis muscle above here. Temporalis muscle which extend deep to the zygomatic arch. This is zygomatic arch, cut section in zygomatic arch, temporalis muscle. This is masseter. Then the muscle inside here is going to be what? From inside the mandible is going to be medial pterygoid. You know which muscle deep to the medial pterygoid is going to be constrictor muscle, especially middle constrictor muscle deep here. Middle constrictor. So this is a mandible. Okay, mandible. What happened? This is the mandible. What happened here from deep fascia? Remember, deep fascia extend until it come to the lower border of the mandible, split, and covering the masseter, and from deep surface is going to extend under medial pterygoid. Okay, so creating two spaces, one outside the mandible and one inside. The one outside the mandible, we call it masseteric space. The one inside here, we call it pterygomandibular space. So this space is called what? Pterygomandibular space. Okay. All together, if you see, this fascia extend to zygomatic arch, and again is going to cover temporalis, creating another space which we call it temporal space. Okay, this is the superficial one. There is another space, deep one, the deep one between temporalis and temporal bone, between temporalis and temporal bone. This is the deep one here, deep, but this is the superficial. So everything here, this space, because it's related to the muscles of mastication, we call them masticatory spaces. Masticatory spaces. Okay, the masticatory spaces mesenteric outside, and we know why we call it. This is the trigomandibular. If I ask you which structure is located here between medial pterygoid and the mandible, what are important structure located between medial pterygoid and the mandible, which located inside this trigomandibular space? Don't forget, we have lingual nerve, inferior alveolar nerve. Okay, so two nerves, important nerves, the inferior alveolar and lingual nerve. They are located in this space. Of course, when we say inferior alveolar nerve, don't forget that usually accompanied by inferior alveolar blood vessels. They are located in this space. And also keep in mind that this space, infection in this area can spread posterior to medial pterygoid and deep to it, so it reaches to parapharyngeal around the constrictor muscle. So if there is infection here, it still can spread to parapharyngeal space, because this is a constrictor, and the constrictor representing the wall of the pharynx. Okay, so this is most important spaces relevant to dental infection. We're still missing important space which is related to the maxilla. Those are related to mandible. If you go to the maxilla, you will see we have buccal space which extend between maxilla and the mandible, and we have canine space. So this is the orbit. This is the inferior orbital foramen. Then there is a muscle just below here, extend to the angle of the mouth, and this muscle is called caninus or levator anguli oris. There is another muscle which extend above the infraorbital foramen and go to the lip. This muscle is levator labii superioris. And which nerve coming through the infraorbital foramen? This is the infraorbital nerve. So this is the infraorbital nerve located here. This space is called caninus space. This space, caninus or canine space. What is the importance of canine space? Canine space first contain important nerve, infraorbital nerve. If you want to block upper teeth, okay, especially the anterior upper teeth. So basically, if you go intraorally from inside here, you have to penetrate this muscle to reach to this space. If you go intraorally, so you have to penetrate which muscle? The caninus muscle. You're gonna penetrate caninus muscle to reach to this space, to block infraorbital nerve. If there is infection here in the maxilla, this infection, okay, can extend periorbital. If there is infection in the upper teeth, can go periorbital. So you will see that your patient have periorbital cellulitis and infection. Periorbital. Okay, so if you see periorbital infection, you can start thinking about upper maxillary teeth. How about the buccal space? Buccal space, if you remember, you have this is trigomandibular ligament, which extend from pterygoid hamulus to the posterior end of mylohyoid line. This is maxilla, and here is the mandible, and then you have buccinator taking origin from this area opposite molar teeth, and this area from the mandible opposite molar teeth, and also from this ligament. So this is the vaccinator, and go to the upper and lower lip, filling the gap between maxilla and mandible. Correct? Okay, behind here, this is going to be superior constrictor, which taking origin also from the trigomandibular ligament. So trigomandibular ligament give origin to vaccinator, anterior, and superior constrictor, posterior. Okay, superior constrictor, posterior, vaccinator, superior constrictor. Buccal space located superficial to vaccinator here. Okay, between the vaccinator and superficial fascia of the face and the skin. So if there is infection in the molar teeth here, in the maxillary teeth, and also mandibular molar, it can spread to this space and go posteriorly to the parapharyngeal space, because here is the constrictor of the pharynx. It can spread posteriorly to parapharyngeal space. Then you have also this infection or this buccal space communicate with submandibular and sublingual space. So basically, if there is any infection in the molar teeth, it can spread to sublingual, submandibular, and at the end is going to parapharyngeal. One thing just remember, keep in mind, mylohyoid line like that. This is a mylohyoid line, and you will see the root of last molar extend to mylohyoid, and this is somehow is little different from the rest of the teeth, which somehow it's above the mylohyoid line. So basically, infection in the last molar, mandibular molar, it can be can spread to the sublingual and also submandibular. Anterior teeth more toward sublingual, because this is again mylohyoid line. When we talk about mylohyoid line, it is the one which separates sublingual from submandibular space, because mylohyoid muscle separating sublingual from submandibular. So keep in mind that the root of the last molar extend below the mylohyoid line. That's why infection here can easily go directly to submandibular space, different from the anterior, which mostly go to sublingual. Okay, so keep in mind that buccal space can receive infection from maxillary and mandibular. So if I ask you the direction of spread of infection from maxillary teeth, it can go up to canine space or posteriorly to the buccal space, However, in mandibular teeth, it can go to sublingual, submandibular, and also vaccinator, buccal space, and also extending backward to the parapharyngeal, and the trigomandibular. Okay. So everything, once it comes to parapharyngeal, there is a possibility to go retropharyngeal and extend down to the mediastinum. So we keep mentioning the mediastinum. Remember that here is the vertebral column. This is vertebral column. If we see, this is the pharynx, and extend down, become esophagus, pharynx, esophagus at the level of C6. This is buccopharyngeal fascia, which extend behind the pharynx. This is buccopharyngeal fascia. And here is prevertebral fascia anterior to the vertebra, which extend anterior to the vertebral column, the whole vertebral column, even to the pelvis, extend to the pelvis. Okay, that's why if there is infection here in the prevertebral space, it can extend it down to the pelvis. Then you have another layer, we call it alar layer, which extend down up to thoracic vertebra number 2, thoracic vertebra. This is the alar layer of the deep fascia, alar layer. So the space here is called dangerous space. The dangerous space. Why dangerous? Because infection, and this is retropharyngeal space. Retropharyngeal space. Okay. So the fascia here is fragile, and if there is infection coming from the pharynx or esophagus, okay, or coming from parapharyngeal, and as you remember, parapharyngeal space can receive infection from trigomandibular, from oral cavity, and it can spread around the esophagus and around the pharynx to retropharyngeal, and the fascia here can be penetrated by this infection and go to the dangerous space. Once it comes to dangerous space, with gravity can spread down to the mediastinum, so this is the direction of the flow or direction of spread of infection. It can come from the oral cavity, from teeth. It can go to the any of the masticatory space, okay, or sublingual, submandibular, and it can go parapharyngeal. Then from parapharyngeal can go retropharyngeal, and from there dangerous space, and then mediastinum. And this kind of infection, we call it descending mediastinitis, descending necrotizing mediastinitis. You can search in the literature about this term, descending necrotizing mediastinitis. So mediastinum, as I told you, the mediastinum equal central part of thoracic cavity, which is located between sternum and vertebral column. Okay, major contents here, it contains heart, pericardium, okay, plus great vessels of the heart, like aorta, superovena cava, etc., plus trachea, esophagus. So if there is infection in the oral cavity and they spread down to mediastinum, you will see this patient suffer from, because of the pressure and the infection, pressure on the trachea, it leads to dyspnea, difficulty breathing. Pressure over esophagus lead to dysphagia, which is difficulty swallowing. Pressure on superior vena cava leads to congestion of the neck, because again, superior vena cava receive venous drainage from the neck. Pressure on great blood vessels, it can end up in lack of circulation to the head and end up with dizziness or fainting. So keep in mind that this can be consequence of oral infection. Okay, can spread down to the mediastinum. So now we understand, like, if we have infection in the maxilla or mandible, maxilla can go to canine space, it can go to buccal space, mandible also can go to buccal space. If this go to canine space, can lead to periorbital cellulitis and edema. From mandible can go to sublingual, submandibular, behind mylohyoid, and then buccal space and submental, submandibular, and trigomandibular, also trigomandibular, can receive infection from submandibular and sublingual, then go laterally to the parapharyngeal. And once it comes to the parapharyngeal, it can spread down to or behind to retropharyngeal, and from retropharyngeal space can go to danger space and down to mediastinum. Okay? So this is how infection from oral cavity can go, either from maxilla or mandible, and it can spread either up or down if it's mainly in maxilla or mandible. But at the end of the day, both of them can spread down to the parapharyngeal, retropharyngeal, and danger space and mediastinum. I hope that this is make it easier for you to understand how facial space in the neck can end up to be dangerous spaces when we have infection in the oral cavity. Thank you.